example, what happens is that each of this sinus, right? This sinus is going to open into the nasal cavity so that no pooling of secretions ever happens here, right? Also try to understand here, the diagram here is very important. This is the orbital structure. See how it is closely related to the frontal sinus, ethmoid sinus, and the maxillary sinus. So orbital extension, there are certain areas which you have to always assess. So orbital extensions are very, very important to be assessed on whatever modality you are seeing, right? Next, if you see that this wall is particularly thin. So ethmoid and its extension into the orbital region is pretty common. So this is the lamina papracia. Papracia means thin like paper. So this is very, very thin. That's why it is a very common pathway for the lesions or infections from here to cross into the orbital region, right? The maxillary sinus will also send out whatever pathology it has into the jaw, like into the alveolar process, into the dental region, and the reverse can also happen, right? So the next thing will be your dental issues, which can be both. So these pathways are all to and fro. So something from here can go into there, and something from there can also go into this thing, right? So next, if you see, frontal sinus is very closely related to the intracranial extensions, right? So these are all bidirectional pathways wherever it can go. Intracranially, it can be like a direct, so it can be involving the bone, the venous sinuses, along the meninges, right? So these are the structures which you will have to see. Whenever you are suspecting that this thing is extending into something, these are the intracranial structures which you are going to look at. Next, if we go on, so let's look at so usually you get a long question on osteomeatal complex. Right? Osteomeatal complex means that you are going to have the ostia and the meatus. So the ostia is the opening of these paranasal sinuses, and these meati are these pathways between the various turbinates, right? So between each and every turbinate, right? So you have, it's easy to remember like this, कि the turbinate which we are saying, उसके नीचे ही that meatus is. So if you have the inferior turbinate, your meatus, inferior meatus is below it, right? So what happens here is that each of the paranasal sinus is going to open in a particular meatus. So when we are talking about the maxillary sinus and the ethmoid sinus, they, as well as the part of the frontal, so they all open across this meatal complex. Okay, so these ethmoid air cells, they create this bulla ethmoidalis. This is the hiatus semilunaris. This is the ostia or the opening for the maxillary sinus, right? This is the middle nasal meatus because this is right below this. This is the middle turbinate. Just below it is the middle meatus, right? This is the inferior turbinate, and this will be the inferior meatus. This is a bony projection which is called the uncinate process. Okay, all these structures. So sometimes you are asked to draw a label diagram for the OMC. So this is a pretty good example of what OMC is about. Why is all this very important? So first thing is that each of these osteas, so this drainage pathway, we have now understood that paranasal sinuses are all air filled. They have a good volume, but look at their drainage pathways. They are so narrow, right? So narrow, very prone to obstructions. So that means that if there is even a little blockage in this whole thing is now like a cut-off system. It is not going to drain anywhere. It has a single opening. So that is why understanding these drainage pathways is important. This is your osteomeatal complex, a combined drainage for maxillary as well as ethmoid, and part of the for the frontal also. Now, if you see, so sometimes frontal can drain here, not always. if you look at the frontal sinus, right? This is the frontal sinus. I am using whichever depiction I find the best. So this pictorial diagram is very important to understand first, because yahi jab when we try to see in CT, sometimes we can get confused because everything will be air containing. So sometimes we may not be able to appreciate these septae so well. And mostly patients will have some kind of variant anatomy. So before we actually go on to cases and try and see this, we should assess this on the pictographical. For frontal sinus, it is very straightforward. The frontal sinus has its proper infundibulum and its drainage path, right? There is usually, so it's usually a norm to find an air cell anterior to this drainage pathway, and that is called agar nasal cell. So agar nasal cells, these are like a normal variant. Um, yeah. So that's like a normal variant for the ethmoid cells which are lying anterior to the frontal recess. There are some variants which are very important. So I'm trying to tell you all those as we go along. Okay. Like this is one of those. Okay. And OMC anatomy is definitely very important. But there are many, many variants which need to be read, especially for some things like the uncinate process attachment, accessory osteas, right? All these kind of things. But there are some which I have covered up here, right? Next, we are looking at the drainage pathway of the sphenoid sinus. This is the sphenoid sinus, and it is draining into, it is draining via the sphenoethmoidal recess. So this is that narrow point where this is opening. So with these diagrams, I also tell you how to look at each of their drainage pathways. Best for frontal is a sagittal view. Best for a sphenoethmoidal recess is an axial view. And for the OMC, the best view is your coronal view. So now that we've understood how to look at their drainage, we have also been able to look at this sinus, right? Look at this sinus. It is very, very clear on this CT. It has a black air within, and you cannot see the walls. No mucosal thickening is seen within it normally. Also, if you see, the walls are pretty smooth. They are always well defined. So with this in the background, I will tell you about two classifications which you have to know always. Paranasal sinuses are a very complex anatomical region. These two classifications you have to remember, because as I said, this area is also very prone to a lot of anatomical variants. Why do we need these classifications? Because the surgeons want to know what is a precarious area of injury. So that is why we classify these things. So Kiro's classification, it tells us the depth of the olfactory region, of the olfactory grooves, right? So when you have these olfactory grooves, you know that their depth matters, because whenever we are trying to treat, we are going to go across the nasal pathway and then try to open these drainage areas. That's what the maximum treatment is going to be for blocked sinuses, right? Surgically. But if this thing is very, it's like very shallow or it's very deep, they have to know that when it is too deep, they're going to encounter it first. If it is asymmetric, suppose on the right side it is something and on the left side it is something, then also they need to know. So that's why Kiro's type classifications have been put in place. So whenever usually you will find patients lying in the Kiro's type 2, 4 to 7 mm. But always be very, very careful for a type 3. And I would suggest that whenever you are getting a value which is in between, right? There is a millimeter left in between here and there. Try to assess subjectively in which direction are you erring towards, right? So you can always err towards the more difficult thing. Next, there is something called as Delano's classification. So Delano's classification, in that what happens is, if you notice this coronal image, just look at this coronal image. These are your middle turbinates, inferior turbinates. This is the section where you can see both the sphenoid sinuses and you can see the optic nerves. So anytime there is a neural structure adjacent, we are very, very careful. Again, we have a classification for this. Why? Suppose this sinus is completely opacified and we want to empty it. When we are going to go in, we're going to scrape out stuff which is all inspissated inside. So can we damage it? When can we damage it more? When this sinus is kind of covering it from all directions. So initially only one wall, then on two sides, on at least three sides, and when you have an nodal cell. So what happens is when you have an additional different kind of ethmoid sinus cell, then it's a type 4. Right? So I'm just going to label these so that there is no doubt. So here what happens is that as we are going towards 3, the sinus is completely surrounded the optic nerve. So, so I have, so the anatomy is going to take a separate class in itself because paranasal sinus anatomy, you'll have to see section by section. So what happens is that if, for example, let's just see this section, right? Or maybe, so when you're going to take one section wherein you can see the superior turbinate also, it's going to be a little higher up, right? Then the middle one. And so on scrolling on multiple coronal. So if you want, then I can take a class on only sino-nasal anatomies because otherwise it's going to take a very long time if you're going to try and see all of them. So usually this is how your, that's why I've gotten some pictographic ideas so that we can understand. So somewhere very high, you can see this superior concha or turbinate, whatever you prefer. So middle, inferior and superior. So superior you will see is very up, it's very cranial. So when we are going to take the coronal sections, we may actually start seeing these ethmoid air cells very well. Or in our case, in this section, we are able to see these sphenoids very well, right? So what happens is just remember that this is the Delano classification, and we are trying to see what is the relation of the sphenoid air cells with respect to optic nerves. Yeah, right. So, okay. So first we have understood that we have understood that there are drainage pathways for each sinus. Next, we are trying to understand only two classifications. I'm not telling about any other variant, right? Because important variants and anatomy, if you want, we can cover. But there is something called as Haller cell. There's something called as Onodi cell. And there's something called as Agar-Nisai cell. Right? These are all sinus, air sinus cells, right? So what happens in Kiro's classification? We have to see the depth of the olfactory groove. As we are going to approach the nose for an endonasal surgery, we need to understand what is the depth of this, right? Usually, most of the patients are going to have a depth of 4 to 7 mm, right? So this is at the cribriform plate region, okay? This structure is crista galli. Right, crista galli, and this is your lateral lamella. These are the bony landmarks. And between these two, you have this groove, and this is your cribriform plate. So how low is your plate? That is what we are going to grade. So 1, 2, and 3, based on the depth of this. So if it's really deep, the surgeon has to know that the Kiro's classification is type 3, and that is when they will be able to, take care when they do the endonasal surgery. Right? So with that background, let's try and move ahead a little bit. So always trying to remember that in respect to the nose, posteriorly you have the nasopharynx, right? This kind of orientation to anatomy I'm giving so that later when we are trying to discuss the things, it is going to make a little more sense, okay? So this is your nasal cavity. This is what your turbinates look like. This is an MRI section. So we know that just behind the nose, there's going to be nasopharynx, right? Behind the nasopharynx, we have this retropharyngeal space, right? There is a parapharyngeal space, and this is a masticator space. Masticator space has muscles of mastication. Next, if you see this structure where we can see T2, a dark signal right here, I think it's a T1 weighted image. So maxillary sinus, and you can see that there is fat behind it, and there is fat and soft tissue in front of it. This is how normal fat is also supposed to look like, right? Then next, we have now understood that these are spaces which are running close to each other. Masticator space, this is your nasopharynx, your retropharyngeal space, your prevertebral and paraspinal space, right? Okay. And this is your parotid space, this is your carotid sheath, and this is your lateral pharyngeal space, right? Parapharyngeal space. So all this is very, very important just to get a hang of it. Next important structure, very complex, is pterygopalatine fossa. So pterygopalatine fossa is a very, very small uh, region where there is a ganglion situated. So this particular small area is just related posterior to this sinus. That's why I am mentioning this. You can read up about pterygopalatine fossa anatomy. And if you still find difficulty in that, then I can cover that also if you want me to take a PNS anatomy class. But just to understand that this sinus is very closely related to multiple pathways. So this pterygopalatine fossa has connections with the orbit also, it has connections with the brain also. So such places are dangerous because whatever is here is going to go here and it's then going to go everywhere, right? If you see this, no, this is how it is. Okay. So now we have talked enough about anatomy, right? So the best books to read for PNS, it depends on. So for head and neck, usually Soam and Curtin is advised. It's the standard textbook. Also, there are other textbooks also. So every Haga also has a section on sinonasal diseases. There's a dedicated book on paranasal sinuses also. And I think one of our faculties from AIMS has also written a clinico-radiological series on sinonasal imaging. So you can search for that. So those are good, but basic point is to know the anatomy. And then with whatever I'm teaching today, you will get an overview of it. So PNS radiographs, first thing. So when we are doing a radiograph, so usually in this season, you're going to find n numbers of PNS X-rays. So what views do we want to do? So first of all, we are going to do a Caldwell's view, right? In that, what is happening is this is the detector and this is the patient, right? So the frontal region is touching the detector and the beam is coming from the backside. So it's an occipitofrontal view. Okay. That is how you just remember it. If you can remember the degree, well and good. It's 15. If you cannot, it's all right. So this is the Caldwell view. Sometimes in your exam, you can be asked that. What do we see in the Caldwell view? We can see that first of all, you just check for the symmetry that all the structures have to be on either side of the midline. You can, excuse me, you can see the frontal sinus. You can see the orbits, right? You can see part of the ethmoid air cells. This is your lateral nasal wall, the floor, right? This is your nose, nasal septum, inferior turbinate. These are your maxillary sinuses, right? So this is how your Caldwell view is going to look like. In this, we have to, so that's a little extra. Okay, audio. Am I audible? I I think there's no issue of audio at my end. Anyways, yeah, okay. So next, so first of all, just remember, okay, so occipitofrontal, okay. I'll just quickly tell you so that we can move on to the major things which are going to come in exam and come in questions. PNS radiographs, 3 views. Only 3 views you have to remember. Caldwell view, water view, and you're going to remember the lateral view. Remember Caldwell view as occipitofrontal. Beam is coming from the occipit to going to the frontal. So here the frontal is touching the X-ray plate, right? This is what you're going to see. So because your X-ray is going to come from backside, your petrous bones are going to project lower. Okay, your bones are here. Okay. Next, if you do a Waters view, what happens in that? It's an occipitomental view. So your chin is on the X-ray plate. Look at this. Your chin is near the X-ray plate, and now you're getting a beam from here. What happens here is you're able to appreciate the maxillary sinuses really well. You're able to get a clear view of frontal sinuses, ethmoid, the centrality of the septum, right? And last is the laterals. This is to look for any kind of air fluid level if there's any. You're able to see the maxillary, you're able to see the ethmoid and part of the frontals also, right? So these three only you have to remember. So whenever you're reading, I have put in all these lines also here, right? So usually that's how they will ask you, okay, how to position. So this is the line.